I think we'll get started, but I do want to give a brief introduction to what we're going to talk about today. Um, Steve Gerard is with us. He's a nurse practitioner, board certified in both family practice and psychiatry. He has 25 years of experience in orthopedic surgery and physical medicine, 6 years in psychiatry, and Steve currently practices full-time at Paramus Medical Psychiatry in Spanish Fort. He's also on staff at Aspen Grove Behavioral Hospital, and he's a medical director for Maple Lake Academy and the Utah Healing House as well. His practice consists of medication management for all psychiatric disorders. He also uses transcranial magnetic stimulation and ketamine for conditions that have not responded well to traditional psych medications, or for patients maybe that are looking to reduce or eliminate, where possible, the need for psychotropic drugs. So I'm really excited to hear what Steve has to present today, and I think we'll turn the time over to Steve.
All right, great. Thank you. All right, welcome everybody. This is a new format for me. The last time I did this was about 3 months ago. Spoke about ketamine to about 500 chiropractors. They were a pretty good audience, even though most of them are pretty much against medications, but it was pretty good, and they're pretty well versed in the anatomy, or I should say the chemistry of how things work, so it was great. One of the reasons I've been willing to talk to people about ketamine is because I think there's a lot of hype about it. People get excited about it, and we hear the stuff about the psilocybin, the mushrooms and all that stuff. And we live in a society where everybody wants a quick fix. And truthfully, ketamine has been found to be probably the fastest acting medication out there for depression, maybe some PTSD, anxiety, stuff like that. But it's not an end all be all. But it has been very helpful. There is some also research on its long-term benefits, and we'll talk about that just a little bit. We call it durability. Generally, a lot of what I like to first start out is talk about a little bit of history on ketamine and kind of understand where we got to this point using ketamine as a medication for these certain situations. Ketamine was actually developed in the early 1960s. It was actually used as a battlefield anesthetic in Vietnam. And you watch the different war movies and everybody's, oh, somebody's hurt, give them some morphine. The problem with morphine is morphine will actually drop your blood pressure. It will slow your heart rate, and it'll slow your breathing down. And so really, sometimes that would, that could actually finish off the soldier. Ketamine, on the opposite side, and we'll get into some of the physiology with this, is ketamine will actually it kind of excites things, but it also hits those opioid receptors, so it actually helps with pain, but it will actually open up the bronchi, so it will increase your breathing, increase oxygen to the brain, which is important. Again, we'll talk about that later. It will bump up your blood pressure, something we have to worry about, or not worry about, but be cognizant with when we consider somebody as a candidate for ketamine. And if I didn't state already, it'll make your heart rate go up. So, and it also causes a bit of a disassociation. So that person who's injured, and in fact, right now, these days, ketamine is found on lots of ambulances. And they will use that to help people. Somebody's stuck in a car, and maybe the car's all wrapped around them. When they use the jaws of life, they will actually give that patient a little bit of ketamine if ordered by the physician at whatever hospital that they're communicating with, to put that patient in kind of a disassociative state, so they're not combative and they're not worked up about what the EMTs are doing and the firefighters and police are doing to help extract them. And so it's been very helpful with that. I remember 32 years ago, in fact, it was June of 32 years ago, I walked into the operating room my very first time, and I was an anesthesia tech as I was going through school, and we had ketamine everywhere. And this is back in 1992. Ketamine was not a controlled substance. It was just sitting all over the place. Nobody thought anything about it. And then in 1999, because of the misuse of ketamine, used as a date rape drug, people just using it as something to chill out on, it became a controlled substance. So it's a controlled three substance, somewhat like, some of your opioid drugs that you take that your doctor will give you after having some surgery. I think actually like Tylenol with codeine's either a 3 or a 4. So anyway, it's been around for quite a while. Again, you have to go through lots of scrutiny to be able to even get ketamine in your offices. I think the application, oh, my phone's going off. And anyhow, anyway, I felt like filling out a application for I apologize. I thought I had my phone off. Anyhow, it felt like I was filling out an application to buy a home when I was trying to get ketamine to my office. So there's a lot of scrutiny, but I think we're really safe with it. There are probably about 50 different centers here in the state of Utah that I've been able to count that do ketamine. So there's a lot of places that do that. Ketamine, while it's being used, is off-label. Ketamine, if you go look at the FDA has only approved it as an anesthetic. So when we use ketamine for anxiety and depression and pain and PTSD, and I think maybe they quasi said it was okay for pain because it's an anesthetic, but we are using it off-label. What does that mean? Is that insurance companies don't necessarily pay for it. And so it usually is a cash, it's usually just patients are paying cash. They can use their HSA cards and stuff like that. I do know that the VA is looking into some of the sites here in Utah to be able to allow some of the VA patients to go and do that. I know Intermountain does IV ketamine. I'm just not sure what the reimbursement is, if they're able to somehow just squeeze it in at places. I even know we talked about it at Aspen Grove a couple of years ago, possibly of doing it. But again, it's a hard to get the reimbursement for it. There is, however, in fact, and I can't say with authority much about it until maybe after this next couple of weeks, I am going to a lecture on Spravato. Maybe if some of you have heard about Spravato. And it is a FDA-approved ketamine, and a patient actually has to self-administer it, and they squirt it up their nose, but they have to be here in the office when they do it. When they do that, they'll do it twice a week for about 4 weeks. It is fairly expensive. Between the physician fee and the medicine itself, it probably comes out to about $1,000 per treatment. That being said, if somebody's already hit their out-of-pocket deductible and and their insurance company approves it, then hopefully there's not much coming out of their pocket, and then they can go ahead and use that. And there's good research to show that it's been backed up. The difference between the Spravato ketamine, it's called S-ketamine, it is a kind of an isomer, kind of a mirror image of the ketamine that we're using here in the office. And we can get into the politics of that. But really what it comes down to is regular ketamine, a vial of ketamine for myself that I could use for multiple patients is about $20. And again, this little thing right there is about, for each patient is about $700. So there's not a there's not a financial incentive to really do a lot of research on just the regular ketamine. Hopefully down the road, it will become more mainstream. Hopefully the FDA will approve just your regular old ketamine as something to use for what we're talking about today, and it'll be approved by the insurance companies. So that's a bit of a history. Again, a lot of patients are doing that. And actually, I should just probably say, so when patients come to me, I only do the IV ketamine. What I like about it, and I'll probably talk about it a little later, is that I have control of it the entire time. If I have a patient that I give the first 5 milligrams and they don't like it, we can just stop. If you spray something up the nose, if you give an injection into the shoulder, it's done, it's over with, and then you can't bring that back. So anyway, that's really what I like to do. Let's get a little into the pharmacology of it. So as I stated before, ketamine is an anesthetic and has been used for years, about 50 plus years as an anesthetic. It's been very popular. Again, it kind of lost its flavor. Everybody stopped using it for a while just because of the bad press. But it really has gained use of back again. So what ketamine does is it gets into your brain, it gets past that blood-brain barrier pretty darn easily, and it affects the NMDA receptors. And if you're familiar with NMDA receptors, those are the receptors that are really important in your brain for neuroplasticity. And whether we're doing a talk therapy, whether we're doing ketamine, whether I'm using my TMS machine, whether we're doing anything, that's what we're trying to work on, is more neuroplasticity for people so they can learn to adapt and overcome in their lives, and so they can build that resilience. Because I think that's pretty much what we're all trying to help people. We can't give a drug necessarily to make hard things not hard and sad things not sad. But we do want to help people with their resilience so that they can live their best journey in their life. NMDA is a huge part of that neuroplasticity. Interestingly enough, though, ketamine is actually an antagonist to the NMDA receptors. And you think, well, wait a minute, it's blocking it. That is correct. But there's essentially two types of receptors there. There's one that's an inhibitory receptor, and then the other one is the excitatory receptor. And the inhibitory receptors is where ketamine has its greatest affinity. And so it goes over there and it locks on there. Well, there's a chemical in our body, it's called glutamate. And glutamate is very important as a neurotransmitter like serotonin and all these other drugs or chemicals in our body to signal things to do one thing or another. So what happens is at that receptor site on the NMDA or the NMDA receptor site that is the inhibitory, ketamine comes and it kind of blocks that site, and it doesn't allow glutamate to hit that anymore. What that does is then that allows more of that glutamate to go over to the excitatory site. And it hitting the excitatory site, that starts a cascade of chemical reactions in the body that help with the whole neuroplasticity. In fact, you may have heard of a chemical in your body. It's called BDNF, brain-derived neurotropic factor. And brain-derived neurotropic factor is really important in synaptogenesis. And we've all heard about synaptogenesis. I mean, the synapses, that's where we make new connections. And so when we're learning new things, we make actually physically new connections in our brain. And so that BDNF, when it is created, it helps us learn easier. It helps us essentially rewire the brain. And so that's where the hypothesis is that how ketamine helps. It's not the ketamine itself. Ketamine is just sitting over on that inhibitory receptor site and allowing all that extra glutamate that would have hit the inhibitory receptor to go over to the excitatory receptor, start that chain reaction. And like I said, it gets to that point where you have the BDNF, that BDNF, or brain-derived neurotropic factor, gets things going. So your body, your nerve cells now create new connections with other brain cells. The same thing happens when you're learning something. You're learning to play the guitar, you're swinging a golf club, you're trying to play the piano, and you're doing it over and over again. And it causes stress. And that stress kind of helps you work through it. And little by little, it's saying, if I'm going to have to do this, I need to learn to get it right. And so that excitatory reaction starts taking place. And again, that BDNF. And then it starts helping us. So you have to kind of put all that work in. ketamine, in a way, can help us kind of bypass that or really get that going so that we can make these new connections in our brain. Why is that important with psychiatry and mental health? Because there's evidence that shows that people with depression, the excitatory receptors, the NMDA excitatory receptors are kind of dumbed down. They're not being activated, and that we're not making new synapses. And in fact, when we use the TMS machine, and it's about right here on the head, that's what it does. It's trying to get everything kind of jump started and going. And then once that happens, we make new connections and new connections and new connections. And you guys see that with your patients, with your therapy patients. It takes that little breakthrough. And so you start having breakthroughs, and then you can kind of work on all that. And so, again, we're trying to build that neuroplasticity with the ketamine and trying that chemical reaction. Now, that's part of it. The other part of it, I believe, and there's research out there, is just that opportunity for the brain to go explore where it wants to go. Now, we'll jump back to when a patient comes to see me, and forgive me for skipping around, but when a patient comes to see me for the first time, if one of you were to send a patient to me, or whoever sends the patient to me, I'll spend about an hour with them and do essentially a full psychiatric evaluation, just like I would do for any patient that's coming for medication management or anything. And we'll look at the medications that they're on and see what works and what doesn't. Some patients get a little frustrated with me because they come in and they go, well, I thought I was going to do ketamine today. I'm like, no, look, we got to see what you're on, if it's helping you, if it's hurting you. We need to set the groundwork for the ketamine to do its job. Also, I've had patients who have done ketamine a couple of times, and they were so focused on something that was negative that kept staying in their mind. I said, you know what? I can't see you anymore until you see a therapist. You need to start working through some issues. You need to start developing some coping skills, and then let's put the ketamine and those coping skills together, and let's work, that way. And so I've sent a number of patients away, or just told them they need to let me know that they've been seeing a therapist for a while, and I have had contact with therapists. I know there's this thought out there about doing therapy during ketamine, and maybe some of you have done it with your patients. I personally have not found that to be very helpful. If a patient wants to do therapy, and I've had some that have come here, they've been with me after we've taken the IV out and such, I'll put them down in another room. We've got another room that has like some massage chair, and they sit in that. They can get on their computer like I'm doing with you guys right now, and they can do a telehealth with their therapist. I've had a couple therapists talk about wanting to come in that hasn't realized yet that they want to. Any of you in the Spanish Fork, the Provo area would want to do that, that'd be great. If you want to sit with your patient in another room after, we can provide that. Because there is kind of an awakening, a processing to sort of a period for about an hour after, and they sit here with me for about an hour after. And I think that's can be beneficial, and I'm usually the one that's just sitting there with them for almost those 2 hours. Sorry, I digressed. I think there is that time when the patient is having that disassociation with the ketamine, that those inhibitions that they have, those negative thoughts, a lot of people can kind of put those to the side. And I really encourage them to just try to explore in their head where they'd love to be. People will ask, well, am I doing this right? I said, there's no right or wrong. Just go find a happy spot, the beach, the mountains, with somebody you love, whatever it is. And I let their brain just go from there. Because what we're trying to do is, again, we're trying to induce those positive feelings in their head. Some people don't feel like they deserve to be able to have happiness in their life. And so I get a lot of veterans, by the way. In fact, I get a lot of EMT, I get a lot of police officers, and I get a lot of active and military and veterans that see me. Almost about half of the people who come to me for ketamine fit that criteria. And anyway, so I think that's just kind of it's a relief of the brain. And then there's evidence that this chemical process that I was talking about, that is actually taking place for days after. The usual process for most people that want to do ketamine is twice a week. If they're going to do IV ketamine with me, it's twice a week for 2 weeks. Then the third week, it's one time a week. And then the fourth week, another one. That's not to say that it can't be just 6 sessions and 2 sessions a week for 3 weeks. We can always do that for people. And anyway, there's not an issue necessarily with that. Again, with the Spravato that I was showing you guys, that's kind of the protocol that's out there. There is something out there also, it's called troches. If you've ever heard of troches, it can be compounded to ketamine. It's like in a little gum, little waxy gum, and the patient puts it sublingual in their mouth, and their body will just absorb it, and they have to just keep it there for about 5 minutes, and it gets into the bloodstream. It doesn't go past the liver the first time, and so it's a higher rate. What I do tell patients, the reason I like ketamine IV is because it's 100% bioavailable. In other words, if I give a patient 50 milligrams of ketamine, that means they're getting all 50, and theoretically all 50 milligrams should be available to the brain. If you get the IM, so an injection into the shoulder, it is about 80 to 85% bioavailable. It depends on where, how deep they stuck it. If the patient's got a lot of adipose tissue, and maybe they got it into the fat instead of into the muscle, and it's not absorbing well, that could be an issue, especially if whoever's injected, if they injected as they're coming out, some of it again gets into the fat, then it's going to have longer effects, but maybe not as intense. There is the spray that some of the compound pharmacies will make for patients that they can squirt up the nose. I'm a little hesitant. I've only had a couple of patients that have used that. These are things, and let me say the spray and the troches are things that people can use at home. I don't prescribe the troches or the spray at home unless somebody has actually been my patient here and done the IV ketamine so that I know how they're going to react. I would actually say about 98% of the time we've done it here, we've had some really good reactions. We had a lady who was insisting on listening to a certain rock and roll from the 60s or 70s that was a little intense, and she goes, "Oh no, I really want to listen to this." And I'm like, "I don't think it's good." Anyway, we let her listen to it, and she got very anxious, and I just stopped it. And as far as even the ketamine itself and the music she was listening to, most patients, it's just kind of a relaxing situation. They're in a recliner, they've got headphones on. I provide little disposable masks for them, and they just lie back, relax, and but they can hear me. It's not so much the volume's not too high with the music, but again, it's just some relaxing music, and I will just titrate that ketamine for them. The dosages of the ketamine are essentially 0.5 milligrams per kilogram, if anybody cares. So if you're 100 or 220 pounds, 100 kilos, that would mean you'd get about 50 milligrams of ketamine, which is about a sixth of the dose you'd get for an anesthesia. So most patients, I start them on about 0.5 milligrams per kilogram. And what I do is I just have it drawn up in a syringe, and I just dose it, mainline it right through the IV. I'll give them a little 5 milligrams initially, see how they do, and then 10, and another 10, and another 10. A lot of patients can have issues with nausea. So if you have a patient that has lots of issues with nausea, then we need to make sure that they get, actually everybody on my patients gets Zofran. If you're familiar with Zofran, it's a anti-nausea drug, and I give that to them IV. Contraindications, just so that you would know, patients that you might have out there that are talking to you about ketamine, or you're thinking about ketamine for them, patients that would not be candidates. Number one, somebody who's had a bad reaction in the past. Number two, high blood pressure. If their blood pressure is not under control, we can't do it. And so and all my patients, I know they come for a psychiatric visit, but I always check my patients' blood pressures just for the regular medication visits. The thing of it is, I'll have somebody that'll start out as systolic at about 130, and they can get all the way to 155, 160. And so then that requires me to give them beta blockers and stuff like that. And I subscribe to the KISS method. If you guys know what the KISS method is, keep it simple, stupid, or in my case, keep it simple, Steve. It's about the same. I try to keep things as simple as possible. I do have patients that I will give them a tiny bit of a lorazepam, 0.5 milligrams, that they will take whatchamacallit, a little tablet about 2 hours ahead of time, or just maybe an hour, and just relax them, because if they come in a more relaxed state, then I think their experience is going to be better. Anybody who's had a recent heart attack, anything like that in the last year, I won't do it because it is excitatory to the heart. I have had a few patients with bipolar disorder that are really pretty strong with the more depressive, and it's just a case-by-case basis. I have to find out if they've used lots of marijuana or things like that. We have to be very careful with patients with bipolar. And so make sure that if you're going to send somebody to get ketamine treatment, that they're going to go to a place that's been working. Talk to them first and make sure they've got providers there that are comfortable with working with patients with bipolar, and that patient's mania, hypomania has to have been under control for a good while. No, I will not do it on anybody who's having issues with current psychoses, schizophrenia. There's too much that can go on there. The liver and the kidneys, those have got to be doing well. I do have a patient that's done very well. She's had some kidney issues. I sent her out for labs. And I know this sounds very onerous just to come get ketamine, but it's got a 2.5 hour half-life. And so it's going to sit there in their body for about 12.5 hours. And, you know, when you're going to send a patient away 2 hours later, you want to be pretty sure that their body's processing this properly. And you're not doing this in an operating room, you're doing it in your office. And so you want to be very careful. Anybody who has pulmonary hypertension, that's even if they've just got regular hypertension and it's stable, we can do it. If they got pulmonary hypertension, I won't touch it. On a case-by-case basis, if people are using THC, if they're using a lot of alcohol, I've just got to see what that patient's intentions are. I've had some really great patients. I mean, I've got a patient that refers everybody to me. And I helped he and his girlfriend, now fiance, really get off of the use of marijuana and alcohol with the use of ketamine. And so that's been great, but they really have to make a commitment to you. And you can't have also somebody who's been using lots of alcohol and they say, oh, okay, well, I'll just stop for 3 days, because then the inhibitory receptors that alcohol's always hitting, those aren't going to be hit. There's GABA receptors, and you could actually maybe put a patient into a situation where you could cause a seizure, and you don't want anything like that. So we've got to be just so careful. And anybody with any adrenal diseases, we need to be so careful with them also. So again, that's why we really have to spend about an hour. I do a pretty significant medical workup on those patients in my psychiatric eval to make sure that they are a good candidate for the ketamine. Trying to think if I'm missing anything. We'll get hit a lot of things just with the questions. As I stated before, ketamine is not approved by the FDA, but the FDA does not dictate medical practice, nursing practice, anything like that. It's just big. It really comes down to insurance is going to pay for it. There is a consensus that came out in 2017 by the American Psychiatric Association. So they do support the use of ketamine. Again, there's just some other politics that are involved with it. There are a lot of university studies that are being done with ketamine right now. As Joseph mentioned before, and I've mentioned, I use TMS, transcranial magnetic stimulation. We have used that in combination with TMS. And the two together working on neuroplasticity has been great. And there's also a lot of great scholarly articles that you can look at that can help you. Probably one of the last things I would talk about, somebody might ask me about serotonin levels, how it affects serotonin levels. It can boost them up some. However, if you look at some of the most recent research, and I'm not here to poo-poo SSRIs or SNRIs, I use them, but the more research that's out there, there's not this strong correlation that we used to think of, that serotonin was the big main player in depression. I think it has something to do with it, but we do know that serotonin, 80 to 90, maybe even 95% of the serotonin's in the gut. And in fact, that's why some of us, when we give patients these SSRIs, they get their gut issues and then they don't want to take the medication anymore. Anyhow, I think the medications are great. They've helped a lot of people, but I do think ketamine has its place. Again, it's not a panacea. It doesn't cure everything, but I think it does have its place in helping people, especially that have been otherwise medication resistant to have had medication resistant to depression, PTSD, anxiety, and a lot of people with their fibromyalgia. This was stated before, I have lots of years in orthopedic surgery, and then I went back and did a postgrad program in psychiatry. And it's kind of the chicken or the egg. Is it depression, or is it the fibromyalgia, or do they kind of just, feed on each other? Had a young lady we were doing TMS up until about 2 months ago. Continues to have migraines, but the TMS has helped. The ketamine has helped. She's more resilient. She still has the migraines, but she's more resilient and she's enjoying life. And I think, that's really our goal. We can't maybe get rid of the migraines. We maybe can't get rid of hard situations in people's lives, but we can help them to be resilient. So I guess that's the end of kind of my lecturing. I'd be more than happy to, any questions that anybody has, I'm more than happy to answer those and get into that.
Yeah, it looks like we have a few questions that came in chat, and you may have already answered a few of these. For example, Paula had asked earlier, are there any adverse side effects to ketamine? I know you kind of covered some of those, maybe just in a nutshell review for us, things to watch out for.
Yeah, so again, the physiologic, as far as nausea, high blood pressure, there are some people, because of the excitatory factor, it can get things going and they can make them really anxious. That's why I started a very low dose with a lot of people, and we just kept make that first session a very comfortable. They just a little bit of a disassociation, but I want them just to be comfortable with it. Usually those sessions 2 and 3 are when they get those, oh my gosh, those epiphanies that may happen with them. But yeah, blood pressure, even though we make the blood pressure go up, then it can bottom out. I have to keep a crash cart in my office. And so I have the defibrillators, I've got oxygen. I've only had, I think, 2 patients in this past year and a half that I've even had to put a nasal cannula on for them to even need that much, just supplemental oxygen. But again, I used to do this sort of stuff as a special procedures nurse some 20-something years ago. So I just try to keep them right there. But yeah, that's probably the thing. I do have patients that will re-experience trauma. And so again, that's one of the reasons to find out what kind of trauma have these people experienced, and then be there for them while they're going through this, to talk to them. And that's, again, the IV, I can just pull the syringe and, just help them through whatever difficult times. But it can reintroduce some of those histories of trauma.
Great. And Holly is asking, is ketamine addictive or can you OD on it?
Yeah, you definitely can OD on it. Yeah, because it has this effect. It can make the blood pressure and everything go up high, and then too much, it can crash you. It can make your breathing, like I said, it opens up the bronchi. It can really help you with your breathing. If you guys, seen people with O2 sat monitors, most of us said about 95. People are sitting at 100. I can really tell where my patient is mentally by watching their vital signs. And I can see the O2 sats high, their heart rate may be at 110 or something like that. Their respirations are a little quicker. But if you give too much, it will crash them. And then you could cause somebody to stroke out if you gave way too much, that their blood pressure could go too high. Addictive, yeah, I would say anything like that can be addictive. As I stated before, it somewhat hits those opioid receptors, and so anytime it hits an opioid receptor, then it can have that. Again, so my patients, to get the troches, they have to see me every month for the first 3 months. If I've got somebody that's reaching out going, oh man, it was great, but now I just need more, or I lost my ketamine. I'm like, we're done. And so they have to know that up front.
I think that's a great segue for the next question. Can you build a tolerance to ketamine? Like specifically, do you need more as you utilize it?
That's an excellent question. And the question is yes. I actually had one patient that needed about 90 milligrams the first time. Then the second time it was about 50-ish, and then about 60, and then 70 to 80, and then 90 was. And so, and some of it is yeah, I think it's both physiologic and psychological. Some of the patients, me as just the practitioner administering it, I start feeling comfortable with those patients. And so I feel that I can help them out a little bit more, because I'm very comfortable how they've responded in the past. Some patients, it's always the same amount. And it's amazing. You can have the same patients, the same weight, and I get 30 or 40 milligrams to one patient and 90 milligrams to the other. And it's just everybody's so different. So again, that's why you want to find out when you're sending a patient or yourself or a family member or friend, make sure that whoever's delivering it is somebody who's worked with, I love ICU nurses and stuff like that, become nurse practitioners, because that's what they've done. They've managed essentially putting somebody in a comatose state. Again, they're not quite in a comatose state here because I can talk to the patients and they can respond back. But yeah, you can build a bit of a tolerance.
Great. This next question kind of comes in two parts. Do you have to do maintenance sessions? And if so, how often? Do you do them quarterly, semi-annually? Then the second part, would someone with borderline personality disorder be a candidate or not?
I'll take the last question first. Borderline personality disorders. I shouldn't even say this thing goes. I've taken care of them. You have to be so very careful, and you have to make sure that you have really strong boundaries with them and expectations of what they're going to get. I've had some borderlines here, or patients with borderline personality disorders, and I always make sure that their family members are in the room, or a close friend or spouse, whatever it is in the room with them, just because, just safety for them, safety for me. But I've done it with them. I'm just going to say that the results, those are probably the patients I've had the least success with. What was the first part of the question?
If you have to do,
maintenance? Yeah, maintenance. Yeah.
maintenance.
Okay, so I do have patients, as I stated, the troches. And so I can give patients the troches that they can put in their mouth. I let them take those. Well, I don't let them take them home. I order at the pharmacy. They pick them up at the pharmacy. But though, again, those are patients that that are my established patients. They're not just coming to me for ketamine as somebody else's patient, and patients that I trust, that have had really positive experiences. They can do the troches, and I'll let them take a number of them, again, get them from the pharmacy at home. And so some of them we use them twice a week. Again, the bioavailability of a troche is about 20 to 30% in comparison to what you get IV, and they get nowhere near the disassociation like they would here. So there are those patients. There are other patients that show up once a month, once every 2 months, once every 3 months. It does vary. Everybody's just a little bit different in what we call the durability of the effects.
And then could it help with eating disorders? Jenny's
That is a good question. We have had patients, I didn't mention this, it's helped a lot of people with some OCD sorts of things, people with smoking, and I did mention like the alcohol. And we do have patients with their anxiety, with eating disorders. It has been helpful. I've had a couple of patients that have come here and done really well with that.
Great. And then I think you've addressed part of this question. Let's see. The question was, can you use this on adolescents who've been exposed to severe trauma? And if so, how young would you go?
That is a good question. So thus far, I have not done ketamine on anybody under the age of 18. When it comes down to it, it's my malpractice insurance. I pay a lot of money to do ketamine because it's an off label. And so I'm, just very honest with my malpractice insurance. And according to them, no way, no how, anybody under the age of 18. There are, however, places here in Utah County that are using ketamine. In fact, there was a kid there at Aspen Grove that was getting ketamine by somebody here in Utah County for his trauma, and did well. Parents, I have seen this child for a while, and anyway, they really were pushing me, and I just said, I'm really sorry, I just can't do it. And I'm not. And there's research out there. There is good research out there that supports it. But I would, again, all those concerns I had, anything else, then you just compound it with adolescence. And so I think you have to be very careful. And my concern is always giving an adolescent a controlled substance. When it comes to kids, I'm just so conservative when it comes to some of these medications, because I don't want adolescents always going to a medication to solve life's problems.
And is there a possibility that ketamine would cause SI or other symptoms to worsen? Could it
Yes.
also worsen mania, for example?
Yeah. Oh, yeah, definitely the mania. I'd mentioned the bipolar and stuff. Yeah, definitely, because of the excitatory factor. Yeah, and some patients, they're so depressed that they don't want to do anything, and now you've given them this energy. Or you give them this great feeling that if they don't stick with it and they're not seeing their therapist and they're not taking their medications, or they go, geez, I'm doing so well, I'm stopping everything else, and then they crash.
And then do depressive symptoms rebound once treatment is stopped, or what do you expect on?
Yeah, excellent question. So what they found is you get a lot of my patients. I mean, I've had patients that have come in and go, are we doing this thing? I said, no, I could probably get you in next week. And they go, no, no, no. And I've had this young lady say, I can't be around my baby. Postpartum depression. And I'm like, okay, I'll come in tomorrow night. We'll do this. Anyway, comes in, we do it. I said, how are you doing? When she's done, she says, well, I don't want to overdose on Lexapro anymore. And she was really happy. So we can get some really quick results. Those tend to taper off within a couple of days. And that's why it's the twice a week for 3 weeks. And then I have them back in 2 weeks, and we kind of assess that durability for those patients. Some patients don't need to keep coming back. We're kind of helping with that neuroplasticity, and they're kind of changing their mindset, and they're doing well. There are others that I'll give them a little troche that they'll put under their tongue once a week and to kind of help maintain that durability.
Great. Did anyone have any other questions for Steve? Is there ever an increased risk of suicide?
Yeah, and like we kind of were talking about that. Yeah, it's just like when you start somebody on an SSRI, any of the medications that we give in psychiatry, there is always that risk that man, somebody suddenly gets that burst of energy, and then they want to uh, go and complete what they were thinking about in the past. Yeah.
Great. And then before I forget, I just want to mention to everyone's present, I dropped the evaluation into the chat. So if you are looking for CE credit for this course, please click on that hyperlink. I also dropped in the class code that you need. And I've listed my email just in case you run into any issues or you need me to email this to you directly or to your personal email if you're unable to access it from work. I'm happy to do that as well. So shoot me an email if you need help troubleshooting that. And then I also dropped in a link to our YouTube channel for anyone who's interested in subscribing. And then if you want to, check out this class later, we'll have it up by the end of the week. So you can look forward to that. Going back to some questions. So have you ever worked with someone with autism and ketamine?
Yeah. And again, just dependent what we'd call higher functioning autism. It's been very helpful with a lot of those patients, a lot of the ruminations and so forth like that, and working through things. Yes. Yeah, it's been very helpful.
Great. I think we might have answered this one, but Amber was asking, can it cause or worsen? Could it cause or worsen mania? Like, is there a chance that it would cause mania?
Yeah, again, we're talking about, remember that the ketamine actually binds onto the inhibitory receptors and allows all that glutamate to hit the excitatory. And so, yeah, it can really get things going. I do have a patient, in fact, I'm seeing him later today, who is bipolar and has done very well. I mean, when he was taking Abilify and all these other drugs, it was making him suicidal. And ketamine has been the thing that has worked for him. And so he's seeing me today, and I've got him on ketamine troches now. And he's doing very well with it.
Yeah, let's see. Do you think ketamine is a good idea in a residential treatment facility?
For adults, yes, I think for adults it may be very helpful for them. Again, it's the reimbursement if they're going to be able to do that, and maybe in an RTC, doing at least 1 or 2 ketamines is IV. If patients respond well, then consider doing some troches. I'm actually, amongst all the other things I do, the same guys that own the Utah Healing House, some of the owners actually have some sober living places, and we down the road would like to set up a place like that, for rehab or at RTC, that we do use ketamine, incorporate ketamine in there.
And then long term, will a patient have withdrawal symptoms when they stop using ketamine, or how do you address that?
No, I mean, like anything else, no, not really. Well, first of all, I guess if somebody was using it all the time, they're getting out on the street, maybe they would have this crash. But any provider out there, anybody prescribing, is going to be pretty tight with what they're giving their patients, and so they're not going to give them enough that it's, unless a patient like hoarded it for a while and then did that. But and when I was in my orthopedic years, my secretary, she called me the narcotic Nazi. So I'm pretty stingy with what I give.
Great. Any other questions for Steve? Someone had asked what Steve's last name is. It's Gerard. I dropped it
Yeah.
in the chat as well, in case you wanted to look him up. Here's a question. I have a client who has struggled her entire life, neglect and sexual abuse in her history. She thought ketamine would be the thing to finally make a difference, but it worked for a few weeks and wore off. Is it likely to have the same results next time?
Perhaps again, that's why if they did the series of 6, it was very helpful. And again, that's why I encourage my patients to make sure they're seeing a therapist every week, that they're working on their coping skills, the resilience, and then perhaps again something like the troches would be very beneficial for them. And then I don't know if every provider out there, I've got a really good relationship with the local pharmacists around here, the compound pharmacies. I did hormone replacement. In fact, I still incorporate that a little bit in with the patients, my just regular psychiatry patients. So I have really good relationships with the pharmacists around here. And so I've always used, again, like the ketamine and stuff like that, or like I said, the troches. So, if I don't know how many of the providers out there use those troches or not, but I think they're very beneficial. They've been great for my patients to maintain those positive effects.
Noel's asking if you have any good referrals in Denver.
I
If you
don't,
have
sorry.
Okay.
Yeah.
This is a great question too. When do you know it's not working? Like they've been doing ketamine for several months, maybe. And at what point do you realize, okay, this is definitely not working for this patient?
Yeah, I actually, after about 2 or 3 times, if they're coming in, I had a guy actually, so he's a vet, and he was just like, yeah, it doesn't do anything for me. I mean, most patients are going to have a kind of an aha moment by the second or third. And his was like, yeah, it's not doing anything for me. So, okay. I thought, I'm not going to keep up on the dosage to try to get there. And I just said, hey, we'll probably just send you on away. I had another patient that during the time, patient with a borderline personality disorder, that just became erratic during it. I had family there. I've actually a couple of them that have done that, and they start becoming very accusatory with everybody. And I said, you know what? I don't think this is the thing for you. So how do you know? It's usually pretty obvious, because the real person, boom, can really jump out. And if somebody is working really hard with their therapist and they're going to be susceptible to the good things, it's going to help. There are some people that it's not going to be for them. And I just say, well, I'm really sorry that it didn't work for you, and send them on their way. Well, after a couple of hours.
Great. Did anyone have any other questions that they would like answered before we wrap up today? If not, I've dropped the chat or the evaluation in the chat one more time for anyone who wishes for a CE certificate for this course, and the class code that you'll need when filling that out. I will be sending those out by Friday, so watch for your email. I echo what Jenny just said in the chat, that this was an extremely valuable session. Thank you, Steve. We had a lot of positive comments coming in.
Oh, they're very kind. Hey, I'm going to give you my cell. This is my personal cell phone. Again, this is not trying to get everybody to send me patients, but if you have questions, because you're going to walk away and go, oh, I should have asked such and such. If you'll just text me, I'll try to get back to you. But my cell number is 385-539-6061. So I'll repeat, 385-539-6061. And it's an exclusive phone I just use for this practice. That way it doesn't get caught up in my other personal stuff. But that way, if you have any questions down the road, that way, if you wanted to send somebody and you say, hey, such and such patient, do you think they're a good candidate? That way we can save them time and money and everything else. And anyway, and go from there.
That's great. Thanks, Steve. Yeah, I dropped it in the chat.
And you don't even have to send them to me. You can send them to somewhere else. That's perfectly fine. I'm just happy to be a resource.
Great. Holly has a quick question for you too, before you go. Do you go through insurance or self-pay, and do you accept Medicaid?
I do go into insurance, but not with the insurances will not pay for ketamine. I've had a patient that showed up here last week and she said, I've got Medicaid. Do you accept Medicaid? I said, yes, I accept Medicaid. She says, well, I was doing Medicaid with the ketamine. I said, I don't think they do. She says, oh, they did. I said, no, I don't think so. However, the Spravato, I'm learning about it. Most insurances, well, and this was what the rep told me last week. He goes, so EMI, so Educators Mutual, PEHP, and TRICARE, or the military stuff, they will not pay for Spravato. So his comment was, not mine. If you've taught the children of our society, if you fought for our freedom, those insurance companies won't pay for Spravato. Apparently the other ones will, but it's going to be a new chapter in my practice. And I just want to, I have a patient that really wanted to do it, and she can't afford the ketamine as far as cash pay. So that inspired me to get hooked up with the Spravato stuff. And so if that answers your question, yeah. And I think Medicaid does pay for Spravato. We'll find out all that. Again, if you've got somebody, ask me in a week or so. That's why you've got my number, and I'm more than happy to answer that. But I think Medicaid and Medicare as such do pay for Spravato.
That's awesome. Yeah, not that we're plugging any particular product, but maybe you
Yeah,
could
no,
hold
I'm
that up
not.
to the...
And they're the only one out there. Yeah.
No, I was just going to say, if you could hold it up to the camera so anyone viewing this either now or at a later point in time, if they need to see how that's spelled.
Yeah.
There you go. Yeah, Spravato.
Excellent. Yeah, and the thing of it is, I make nothing off the Spravato. Like I love it. The insurance companies, they pay for it. The patient pays for it. It gets sent to my office. I put it in my safe. It's got a little tag on it, so I'm not making a dime off the Spravato. I see the patients, but so yeah, I'm not really plugging their stuff.
Good deal. Any other questions for Steve before we end today? I know we're just a few minutes over. We've got a lot of thank yous for your time, Steve.
Oh,
it looks like this was a great presentation today. We have some very nice comments in the chat section.
Thank you. I'll send $1 out to each one of you.
Great. Well, it looks like there are no more questions at this time. Again, thank you, Steve. I think we all learned so much today, and it's just really eye-opening to see, where science is taking us and how we can best help people heal. And this is fascinating.
Yeah. Oh, and just really quick, if you guys want a really in-depth, like 2-hour discussion on this, Andrew Huberman, if you've ever heard of him, he's a PhD at Stanford, neurology PhD. Get on his again, Andrew Huberman, starts with an H, does a great, he talks a lot of stuff, so uses a lot of same terminology that I do on ketamine. He's absolutely wonderful.
Great. There you go. Andrew Huberman, did you say?
Huberman, yes.
Okay.
Yeah, the guy's brilliant.
Fantastic. Great. Well, thank you everyone for your time today. And thank you again to Steve. He was great in answering all of our questions. Again, I'll be sending out the CE certificates at the end of the week. If you have any issues accessing the evaluation, please shoot me an email. Happy to troubleshoot or answer any other questions that you might have. And thank you and have a great week.
Thank you.